Welcome, everyone, and thank you for joining us for this webinar presented by the UCSF Memory and Aging Center and the Institute on Aging. We have Ashwin Kotwal, a geriatrics and palliative care physician from UCSF. He runs a telehealth palliative care clinic and is an assistant professor in the Division of Geriatrics and Palliative Care. He's going to be talking about preparing for a potential coronavirus infection and what are the odds and what are the options. I want to remind people that if they hover down at the bottom of their screen, there is a Q&A icon, and if they click on that, they can type in their questions. Dr. Kotwal will take some time at the end of the presentation to answer the questions, but you're welcome to type them in at any point. I also want to remind people who are enrolled for CEs that they will get an email through Zoom tomorrow with an electronic survey that needs to be filled out in order to get the CEs. So please remember to complete the survey in order to get the CEs. And with that, thank you, Dr. Kotwal.
Thanks so much, Sarah. Hi, everyone. My name is Ashwin Kotwal. I'm, as Sarah mentioned, a palliative care physician and a geriatrician here at UCSF. Really thankful to be here today to discuss a topic that I'm finding has been on many people's mind, preparing for a potential coronavirus infection and thinking about the particular case of dementia, although I think this is very relevant to many people, and thinking about what are the odds and what are the options. Before we start, I'd like to take a moment to allow everyone to just take a deep breath before we jump into this topic. And while people are doing this, I'm going to read a poem. So this is The Summer Day by Mary Oliver. Who made the world? Who made the swan and the black bear? Who made the grasshopper? This grasshopper, I mean. The one who has flung herself out of the grass, the one who is eating sugar out of my hand, who is moving her jaws back and forth instead of up and down, who is gazing around with her enormous and complicated eyes. Now she lifts her pale forearms and thoroughly washes her face. Now she snaps her wings open and floats away. I don't know exactly what a prayer is. I do know how to pay attention, how to fall down into the grass, how to kneel down in the grass, how to be idle and blessed, how to stroll through the fields, which is what I have been doing all day. Tell me, what else should I have done? Doesn't everything die at last and too soon? Tell me, what is your plan to do with your one wild and precious life? All right. Well, we're living in through an extraordinary time. And I also wanted to just pause and acknowledge that everyone's situation may be different. This pandemic has brought stresses from many different directions, including caring for loved ones, juggling childcare, work responsibilities, uncertainty with numerous life situations. And many people just have a lot on their mind. With our group, I'm not sure if I can check in with everyone, but I wanted to invite you all to feel free to post a comment to let us know how you are doing and coping with all of this. And if you have suggestions for the group, we also welcome that. In today's goal, we will be having a fairly open conversation about COVID-19. I'll be presenting some of the information that is available and that has been guiding decision-making in the medical community. Some of this, I acknowledge, may be challenging to hear or talk about. And I also want to make a disclaimer. We are operating in uncertain times. Medical data and recommendations are changing on a week-to-week basis, and sometimes even on a day-to-day basis. So if you have corrections or questions for me based on something you have read, please let me know. Today, we will be discussing the following topics. The first is, what is the current situation of COVID-19? And by the end of this lecture, I hope that you'll be able to identify 3 ways COVID-19 has impacted older adults. The second is, how might you think about your medical options if you or a loved one get diagnosed? And we'll be going through many options, but I hope you can think through at least 2 options for medical care or support by the end of the lecture. And lastly, what can you do to prepare? And we'll discuss how to apply tips for important conversations, preparation, and documentation. So first, the current situation of COVID-19. Coronavirus has continued to spread across the country. Here is a map from the New York Times, which shows that it's had a large impact in cities like New York and the state of New Jersey and other cities. These are the confirmed cases as of yesterday, and the number of actual cases in the community may be higher as we continue to learn about asymptomatic spread. We've been fortunate that in the Bay Area, confirmed cases have been less common, with about 1,700 total positive cases reported as of yesterday. We have also had lower rates of critical illness and lower rates of death, although it has been clearly still impactful. However, nursing facilities and assisted living facilities remain hotspots even in the Bay Area. There have been many news reports that have emerged of outbreaks in nursing facilities, for example, with recent California public health data showing that 6 of 19 nursing home facilities in San Francisco have COVID positive residents. That's as of at least April 30th. There may be higher numbers in assisted living facilities. And I know that many of you have loved ones who live in these facilities, and I just want to acknowledge how challenging this has been for everyone involved with this. There's also been unique challenges in memory care units. Memory care units are open units. They often have wandering residents. In normal times, wandering helps to keep people walking and active. It's not just walking around. It may involve picking things up, touching, interacting with other residents. Best practice dementia care really allows people to do this. But in COVID-19 times, we're trying to reduce this by closing off spaces, even though residents don't really understand. So it's hard to keep people from touching rails or walking, and it's hard to avoid rapid transmission. San Francisco has attempted to create policies to try to reduce or limit the spread of coronavirus. These include, on March 16th, having more restrictions on visitor policies and even on what staff are allowed to go into nursing facilities. And more recently, on May 1st, the mayor just indicated that there should be universal testing of staff and residents every 2 weeks in order to better identify people with asymptomatic disease. And again, I just want to acknowledge that COVID-19, it's been devastating to many family members of nursing home residents and these communities themselves, which really thrive on building community and relationships with residents. If one is diagnosed with COVID-19, the severity of the illness can vary substantially. Here is some data from Italy on the severity of the illness, which is, and this has been comparable to severity among confirmed cases of coronavirus in the US and other countries. So what they found is that about 70% of cases are mild or have few symptoms. Mild in this case means that someone can be managed or observed at home or in their current setting. However, in about 30% of cases, individuals become severely or critically ill. That might require a higher level of care or medical attention. In some cases, people can become sick suddenly, like within the first few days. And in other situations, people start off as having a mild illness and then develop serious or severe illness in the second week or after about 10 days. While it is hard to predict who will get a severe case, it's not completely random. We've been able to identify certain risk factors that increase the likelihood that people might have a severe illness. The strongest risk factor is age. Individuals who are older than 65 years old are more likely to have a severe illness. In fact, if you look at the right panel, almost half of adults over 75 years old with a confirmed case of COVID-19 required hospital-level care. This is based on data from the Center for Disease Control up until around March 15th that showed that people who were 45 to 64 years old were having rates of hospitalization for COVID-19 right around 25%. And these rates increase gradually by age. Other risk factors include having lung disease like asthma or COPD, heart diseases like heart failure, diabetes, obesity, having a medical condition that leads to being in an immunocompromised state like rheumatoid arthritis or other medical conditions, severe kidney disease, liver disease, and nursing home residents are at higher risk, often because they may have lower functional status or many other medical conditions. And older adults and individuals with those risk factors are at higher risk of death if they contract COVID-19. Here is data from the CDC, again, showing the case fatality rate, with rates ranging from 10 to 20%. These rates are fairly consistent with rates being described in other countries like the UK, Italy, China, and others. We really hope that these rates are lower, especially as we expand to more testing. These rates may start to come down as we get a bigger picture of what's going on. In San Francisco, for example, the overall rates of death have been much lower. But I will point out that of the 31 deaths in the Bay Area, 30 of the deaths have been older than 65 years old. So it's an important thing to consider. Now, this is a lot of information that I presented, and many of this may be information that you've already heard. But regardless, it can be really scary or worrisome to think about. My hope is that social distancing will be able to limit the spread of this virus. And regardless of the situation, though, in terms of the spread and how this interacts with policy decisions, I think individually and within our families, is important to think about what coronavirus might mean for our own medical situation. One way to prepare is through advanced care planning. This helps to think through how we might think about medical options if you or your loved one gets diagnosed. So what is advanced care planning? Advanced care planning is, in a nutshell, making decisions for the healthcare that you or a loved one would want if you become unable to speak for yourself or for certain situations that require urgent decision making. There is no right answer here. These decisions are really based on personal values, on preferences, and discussions that you have with important people in your life. Advanced care planning is important for everyone to do because it can help align the treatment options that are available with your values and preferences and really avoid making medical decisions under duress. And why is this important during COVID-19? So as I mentioned before, when people become sick, things can change really quickly. Um, and this can require urgent decision making. Unfortunately, many hospital visitor policies right now are limiting the ability for key decision makers to visit the emergency room or even the hospital. And so, without advanced care planning, people run the risk of getting medical treatments that they may not otherwise want or not having adequate communication with medical staff. And healthcare workers are desperate to know information about patients, especially their wishes. They really want to make sure people are being treated the way they want to be treated, and that while they're practicing medicine, they're not doing harm to people who are coming to the hospital. Sometimes when people do advanced care planning, they think through every possible medical scenario, and in my mind, that can be a little overwhelming. What I suggest instead is having a general framework for thinking about medical decisions and your values, and then working with your medical team to figure out what treatment options best align with your or your loved one's goals. And someone just asked, will I share the slides? Yes, absolutely. So here is one framework that I like a lot. This was developed by Susan Hickman, a nurse PhD at Indiana University, as well as Kathleen Unroe, who's a physician at Indiana University. Basically, in this framework, you can think of medical treatments furthering three main goals. On the left is life prolongation. So this is medical care that is focused on helping a person live longer. The second, shown in the middle, is maintaining function. This is care that's focused on helping the person stay strong and independent for as long as possible. And the third is comfort care. And this is care that's focused on comfort and quality of life. Now, these treatment preferences, they're on a spectrum. So you can kind of think of this as an arrow, and the treatments are not mutually exclusive. But sometimes there can be trade-offs between different treatment options. And so it can be helpful to know which goal is most prioritized. So keeping those three big buckets of personal treatment preferences in mind, let's think through how we might align those preferences with treatment options for coronavirus. And I'll keep referring back to them on the screen as well. So if someone is diagnosed with coronavirus, the treatment options depend on the severity of illness and your overall medical condition. As I mentioned before, about 50 to 70% of individuals have mild disease. And in these cases, the treatment is supportive. People who have mild disease, though, can still have a hard time. Common symptoms include fevers. Sometimes people can have fevers for multiple days. They can feel tired, have body aches, headache, and cough are some of the most common symptoms. For persons with dementia, we're finding that, like when they might have other illnesses, individuals can be restless because their routines are disrupted. They can experience falls or decreased abilities. What sometimes I've seen with some of my own patients that some people have lost the ability to feed themselves, which can be really devastating. And people can also get confused more easily. Treatments in these cases are generally supportive at home or at care facilities. So it might include inhalers or nebulizer treatments for people who are wheezing or short of breath, cough suppressants, treating fevers, and other forms of medical support. We found that medical teams tend to check in really frequently. So people, if they're at home, medical teams may check in through telehealth or frequent phone calls. And of course, if people are in facilities, people try to check in on those particular patients quite regularly. So coming back to our advanced care planning framework, there's not much to plan for here. Supportive treatments are always potentially helpful to reduce symptoms and give the body a chance to recover. These treatments are generally not going to cause harm to function or comfort. However, in dementia, it can take especially attentive staff to guide individuals through those other potential complications I mentioned. So coming back to our treatment pathway, about 50% of older adults can develop severe cases of coronavirus, either immediately or even a week into milder illness. So in severe cases, this includes all the symptoms that I discussed before, and there can be worrisome signs. These might include confusion, low oxygen levels, difficulty breathing, low blood pressure, or other signs of medical instability. As I mentioned before, we're finding that there's two common patterns of developing severe illness. Some people develop severe illness suddenly, a few days maybe after the first signs of coronavirus infection. Others might develop severe illness after about 7 to 10 days of mild illness. In these cases, the treatment really depends on the goals of care and your personal preferences. There are in general two options: hospital care, which may require decisions about different types of medical treatments, including ICU level care, the intensive care unit, and comfort care and hospice. And so I'll go through both of these options. So coming back to our treatment pathway, let's think about the hospital level care first. So hospitals are really used to evaluate or stabilize medical conditions, and they can provide treatments to prolong life. Some of those treatments include antibiotics, oxygen therapy, having closer monitoring, and even intensive care. And people can make decisions along with their medical teams about what treatments are most likely to help or which treatments make sense. There are some key considerations during the COVID-19 pandemic for how hospitals are operating that may be relevant in case you or a loved one need to be hospitalized. The first is limited visitor policies. So people are drastically limiting the number of visitors who are allowed to go into the hospital in an effort to reduce people's exposure to coronavirus. There are exceptions which vary by health system, but some of the common ones include exceptions for certain caregivers, if there are urgent legal issues, or if people are in the last 48 hours of life. Second, even when people experience a quick recovery in the hospital, post-hospital courses can get pretty tricky, especially if care facilities are unable to accept old residents or new residents. So now policies are requiring that people test negative twice for COVID-19 before they can be sent to a nursing facility. So sometimes people can be kind of stuck in the hospital for a while. How do people do when they're hospitalized? Some of the most recent data comes out of New York health systems. Here's a little bit of data from about 5,000 hospitalized patients in a New York health system. They found that of people who were hospitalized, 25% of people were able to be sent home. But about 10 to 30% of people over 70 years old died in the hospital. And these numbers could still change because 45 to 70% of people are still actually hospitalized. That was as of April 22nd. This suggests that these are not simple hospital stays. And these can take many days or even weeks of being in the hospital to recover. With this in mind, um, one medical decision to consider is whether it makes sense to go to the hospital. For individuals who want to prolong life, it makes sense to go to the hospital and consider using available medical therapies. Individuals who want to maintain function should consider the hospital for selective treatments, but remember that prolonged stays in the hospital can compromise people's ability to stay independent or functional. So this should be thought about over time. For people who want to pursue comfort and quality of life over other treatments, it makes the most sense to avoid the hospital, as treating comfort may be best done in more familiar environments with familiar staff or caregivers. The hospital, as many of you likely know, can be a very uncomfortable place to be in many ways. Coming back to our treatment pathway, when people are in the hospital and their medical condition worsens, medical teams may present the option of intensive care unit care. The most common reason for being in the ICU, if one is diagnosed with COVID-19, is difficulty breathing and low oxygen levels. So what do ICUs provide? Well, they provide closer monitoring. This can be done through both putting monitoring equipment on people's skin or in certain blood vessels. ICUs provide life-supporting medications, some of which are delivered through specialized IV lines that feed directly into large veins close to the heart. In COVID-19, the biggest thing they provide is ventilators. So here you can see a picture of a mannequin that's hooked up into a ventilator, which is a fairly accurate representation of what kind of goes into the different hospital, different equipment, and how people are kind of strapped into that equipment for their safety. The benefits to ICU care are providing critical supportive medical treatments. However, there can also be harms. It can be extremely uncomfortable to be hooked into some of these machines, and people generally require getting multiple blood tests per day and really close monitoring. Medical complications are common. People can develop infections from being on the ventilator or having skin breakdown. Ventilators can be traumatic to people's throats or lungs. And especially for people who have cognitive impairment, it's really easy to get confused in the intensive care unit. People are dealing with serious illness. Their whole sleep-wake cycle may be disrupted. And they're getting a lot of different medications, which can mess with how people think clearly. Even when someone survives, people can be severely debilitated, and it can sometimes take years to recover to prior function. And unfortunately, most people do not survive the ICU. And this is data coming out of the recent literature about the COVID-19 pandemic. Where in New York, 7 in 10 older adults who went to the ICU for care unfortunately died in the ICU due to COVID-19 related complications. I will mention though that San Francisco has been a little different. We're having lower rates of death even when people are in the ICU. So it's important to talk with your local hospital teams to learn about what they are seeing so that you can make decisions that make the most sense for you. Back to our treatment pathway. If you're in the ICU and cannot sustain your own breathing, medical teams may consider providing mechanical ventilatory support. What we have found is that ventilators are quite challenging for the COVID-19 pandemic. People develop an inability to breathe on their own, which can actually last for weeks, requiring ventilator support for 2 to 3 weeks sometimes. So when people are on a ventilator, I think you should consider it as a medical treatment they'll be on for at least a week or 7 days. Sometimes when people have short stays on a ventilator for other medical conditions, they can bounce back. But the longer you're on a ventilator, the harder it is to recover. In New York, for example, on that same sample of about 5,000 patients, they're finding that so far, just 1% of the people who are on a ventilator um, have been sent home alive. 30% of people have died while on the ventilator, and 70% of people are still in the hospital on ventilators. Um, Obviously, these situations are just heart-wrenching for so many reasons, and it will be really important to see how people do over time. And so coming back to our framework, how should we think about ICU level care? Well, if one wants life-prolonging care, you should consider therapies available in the ICU, including mechanical ventilation. But remember, there can be trade-offs with the ability to maintain function, even afterwards, or to be comfortable. ICU teams generally really try to make an effort to address these issues, to try to make it possible for people to recover or to be comfortable. But even the best of efforts can be limited. If the goal is to maintain function, certain ICU therapies may make sense, but others may not, like being on a ventilator, which can be hard to recover from. For comfort care, it may be reasonable to avoid the ICU and consider hospice or in-hospital comfort care if health conditions worsen while hospitalized. So let's think about the option of comfort care and hospice services. Going back to our treatment pathway, the point that I want to make here is this is always an option to shift the focus of care to aggressively addressing comfort. It can be done in multiple settings, including at home, a facility, or the hospital. So you can avoid going to the hospital and directly think about comfort care. Even while you're in the hospital, you can shift the goals to really aggressively focus on this. What does this mean? Well, comfort-oriented care includes treatment of difficulty breathing, fevers, or other uncomfortable symptoms like pain, nausea, or other side effects. Hospice care is a type of medical care that specializes in providing comfort care to people who are in the last days, weeks, or month of life. What do? So hospice teams include they include an interdisciplinary medical team, including a medical director, nurse practitioners, RNs, social work, chaplains, and volunteers. And they can visit the home or living facilities. They often visit nursing facilities and certain assisted living facilities, for example, to provide specialized care focused on comfort. They have 24/7 phone assistance, which can be especially helpful for people who are at home. And in-person visits may vary. I think they really rely on people receiving care from caregivers who are at the facility or at home. During COVID-19, hospice agencies have been enrolling patients who have COVID-19 to help optimize their comfort, support families, and address symptoms. And they're often using telemedicine so that they can do check-ins more frequently and limit exposing people or exposing themselves to COVID-19, or they have dedicated teams who have personal protective equipment and who are really prepared to support people who are diagnosed with COVID-19. So I just want to mention that while there are trade-offs between these different approaches to care, we always want to think about how to care for you or a loved one and ease suffering from illness. Palliative care teams, for example, can assist in improving quality of life and talking through what is important at any stage in serious illness. How about cardiopulmonary resuscitation, or CPR? So everyone should think about whether they would want CPR if their heart stops or they stop breathing. So what is it? It involves firm chest compressions that are administered when a person's heart and breathing stop. And the goal here is to restart their cardiopulmonary function. Some of the medical orders you might have heard about are full code, or do not resuscitate, or DNR. So some of the benefits, it may prolong life in about 1 of 10 older adults. But there are some serious harms. And I like this graphic here that kind of illustrates what can happen if somebody experiences a cardiac arrest. So while it may prolong life in 1 of 10 older adults in general, survivors almost always have brain damage. People can experience broken ribs or organ damage during the chest compressions. And it requires intubation and ICU level care if there's a successful outcome where there's the heart and lungs are restarted. In the case of COVID-19, there's limited data, but what we've found is that CPR is even less successful. So from data coming out of China, we found that 2 in 100, rather than 10 in 100, adults over 60 years old survive for 30 days if they require CPR. And it's unknown how these individuals do over a longer period of time. So coming back to our framework, if considering life prolongation as the most important goal, it's reasonable to consider going through CPR. However, if maintaining function, comfort, or quality of life are a priority, then consider being do not resuscitate, or DNR. But it's important to talk with your medical team about this either way. So we just went through a lot of information and potential medical decisions. Practically, how should we think about moving forward? Well, I would suggest a few key steps that you can start on even today. The first is to reflect. Reflect on what is important to you or a loved one. Some questions that you can ask for yourself or a loved one are, what brings me or my loved one joy? What makes life worth living? What would be important to me or my loved one if seriously ill or near the end of life? What might be a quality of life that would be unacceptable to me? There are no perfect answers here, and uncertainty is often expected. Second, it's important to talk to your doctor and loved ones. These individuals can help you learn a little bit about your health status before you start asking some of these important questions or making important medical decisions. And I would encourage you not to be afraid to ask your doctors tough questions. It's often important, and I would definitely encourage involving important family members before, during, or after conversations with your medical team. And a nice resource to start some of these conversations, if you want to have them with others, for example, is the conversationproject.org, which is a great nonprofit website that aids in these conversations. Third, you should choose someone who can make decisions for you if you cannot speak with your medical team yourself. This is also known as a healthcare proxy or a designated power of attorney, or DPOA. So a good decision maker, here are some of the key traits. They know that they're your DPOA. If this comes as a surprise to them, that's not a great sign. They should be available and easy to reach. They should know your values. They should know what's important to you. And they should be capable of making decisions on your behalf. You should make sure you're documenting these conversations and these wishes. Advanced directives are a written document that tell us how you want to be treated. Um, Importantly, they tell your decision maker, your healthcare proxy, how you would want to be treated, especially if you can't go through everything yourself. I like advanced directives because they're not super specific, but they give an overall framework with how people should think about what types of medical care they would want. Everyone over the age of 18 should do an advanced directive. I myself had to do this when I got married to my wife. She actually made me do this. So you can go through these advanced directives and you can sign it even at home with 2 witnesses. So a great website that can walk you through each step is prepareforyourcare.org, which is also a nonprofit website, which was actually developed here at UCSF. Another important document is the POLST, or the Physician Orders for Life-Sustaining Treatment. This is a pink form that many of you may have seen before. And this is really meant for people who have serious life-limiting health conditions or are at high risk of a medical crisis where someone might need to call 911 or be in a hospital setting. This form goes through 3 major areas as to what you would want in emergency settings. This includes CPR or resuscitation, what types of medical interventions you would want, and questions about artificial nutrition. This is a really important form to make sure that your wishes are communicated between medical teams, even in emergency settings. And so I would encourage you, if you feel like you have a serious health condition or a loved one has a serious health condition, that you fill this out with your doctor. So let's go through a couple of quick examples. These are examples I've just made up, so they're not perfect, but I think they can illustrate some of how we approach documenting and thinking about these decisions. So the first is Mr. Jones. He's a 78-year-old who has no diagnosed medical conditions and is physically active. His spouse, Ms. Jones, has dementia, and he is her primary caregiver. He has never filled out an advanced directive before, and he's been reading a lot about the coronavirus. He thinks about his values, talks with his family and medical team. He completes an advanced directive and chooses a DPOA as his close friend. He also works with his medical team to establish the DPOA, an alternative DPOA for his spouse if he's unable to speak on her behalf. So coming back to our framework, he fills out his advanced directive. He notes that he is open to being hospitalized if he contracts COVID-19 or other serious illness. He wants selective treatments in the ICU, but after hearing about the risks of ventilators, he wants to avoid being on a ventilator. And in the case of COVID-19, he would like to be DNR if he suffered a cardiac arrest. Let's think about another example. Ms. Lee is an 84-year-old nursing home resident with moderate Alzheimer's disease. She's frequently found humming songs. She enjoys spending time with her grandchildren. Her daughter, Helen, has been thinking about coronavirus, especially since she was told by the facility that a healthcare worker there recently tested positive. So they talk with their medical team and complete an advanced directive and a POLST form. They indicate that they would not want hospitalizations or ICU treatments, that they really want supportive treatments to be provided in a nursing facility, including antibiotics and oxygen, but really even in that case to prioritize comfort. And she would like her mother to be DNR. And example 3, Ms. Smith, an 82-year-old with high blood pressure, recently diagnosed with mild cognitive impairment. She lives alone and is active in her community and with her extended family. And she's been thinking about her values and preferences and wants to think them through with her medical team. She completes an advanced directive, naming a friend as a DPOA, and speaks to this person about her wishes. And she, after thinking about this a lot, would like to be hospitalized, would like a trial of ICU treatments that her medical team deems might be helpful, including a ventilator, and she would like to be full code, recognizing even the likelihood of poor outcomes. All right. So some of the key takeaways, we covered a lot of ground here, but uh, first is that older adults are at higher risk of severe cases of COVID-19. The second is that we should really consider planning ahead so that your or your loved one's preferences are aligned with the available treatment options and that we're trying to avoid making medical decisions under duress. And third, we discuss simple steps you can take today to have conversations and document your wishes. So I'd like to thank a ton of people, including Dr. Hickman, Dr. Unruh, Dr. Sala, Smith, Kalmar, and Dr. Wadera, all of whom have been thinking about these topics so much and have contributed to many of the ideas and concepts that I discussed today. And I'd also like to thank you all, the Memory and Aging Center, for giving me this opportunity to speak with you all. And I welcome your questions and input.
Great. So thank you very much, Dr. Kotwal. That was really informative. And now is a time for questions. So if you hover on the Q&A icon or the chat icon, you can type in your questions below. And just to let you know, the Memory and Aging Center has a website. It's memory.ucsf.edu/COVID, where a recording of this webinar will be posted, as well as Dr. Kotwal mentioned he's willing to share his slides, so we will post the slides for download there. I had a question that came up while you were talking and wondering, we see it's in the headlines when someone gets off a ventilator, and there are those cases, where people in their 80s do get off of ventilators and are discharged from the hospital. And I'm curious if enough people, we also hear when people graduate from hospice, it's actually very common among people with dementia in particular. So I'm curious if people with COVID are also graduating from hospice, or if there hasn't been enough data on that.
Yeah, that's a great question. So I would say, to answer your second question first, actually, people graduating from hospice who have been diagnosed with COVID, I think it's a little too early to know that for certain how people are doing. For example, Hospice by the Bay, I believe last time I heard about their services, I think they had 1 or 2 people who had COVID-19. I'm sure those cases have increased more recently. But I think it's hard to know about who graduates and who doesn't. Certainly, people have a lower threshold for starting hospice services if they're diagnosed, just to make sure they get supportive care into the home or into the facility early on, so that we're not playing catch up. And hospice agencies are definitely okay with that and kind of graduating people from hospice or discontinuing hospice services if they get better. As you mentioned, a lot of times people graduate, and that support that people receive from hospice can be really critical to helping people through rough times. So I would say that it's okay to err on the side of talking with a hospice agency, potentially starting a hospice services, if that's at all within the goals. In terms of how people recover after being on a ventilator, I would say there are many cases of people recovering from on the ventilator, leaving the hospital, but it can be a really long road to recovering function. And sometimes people spend a lot of time in nursing facilities for rehabilitation, or can be in and out of the hospital for a long time because of experiencing more weakness in their body. So I would say it's very complicated. It can still be very complicated even after you leave the hospital.
Right, going back to that middle panel about function.
Yeah.
So we have a question from Caitlin. If you have any thoughts about the FDA-approved antibody tests that are available privately. I think there's a lot of controversy about that lately. I don't know.
Yeah, that's a great question. Honestly, that's a little bit outside of my expertise, but what I understand is that there are a number of tests that are coming on the market, and it really depends on the patient population we're thinking about. In nursing homes, for example, we're doing universal testing. And so it's really important to cast a wide net and try to capture people because the risk of not detecting coronavirus, even in asymptomatic people, could
Hmm.
be large.
And
It
that's
might
COVID testing, not antibody testing, right?
right, exactly.
Yeah.
That's COVID testing. For antibody testing, I think it's also unclear exactly how important that is. It can
Hmm.
certainly help to tell us about population related prevalence of the disease, how kind of far it's spread into our community, but it hasn't really. It's unclear if immunity, for example, if we detect antibodies, is something that persists or is protective from recurrent infections. So I think there's a lot of uncertainty there,
We
and I
don't
think
really know what
that's
it
actually
means
useful.
yet. Yeah. Another thought I had when you were talking is that I think you mentioned uncertainty, and a lot of people, might be dealing with symptoms, particularly in dementia, like you mentioned, people not eating as much, and certainly just the disruption of sheltering in place, and there's not having visitors can cause changes in people's functional status. But with the changes in access to in-person visits and questions around whether people should go get lab work done, and I'm curious what you think as things are possibly easing up in parts of the country and maybe even in California around those risks and benefits for high risk patients.
Yeah, such a great question. And like you mentioned, there's a lot of uncertainty that we're dealing with right now with how to strike the right balance between social distancing, really reducing that risk of being exposed versus some of these other activities, which are hard to believe are all optional.
Hmm.
Um, and so I think it's really important to talk with your medical teams about this. If you're having trouble, with caregiving responsibilities, food insecurity, getting medications, getting adequate support at home, that we try to come up with solutions there. I think there is room for making exceptions, but I think people want to do that as safely as possible. Are there specific caregivers who could visit people in nursing facilities who have been tested, who know how to use personal protective equipment, who are limiting social interactions otherwise to
Hmm.
reduce their risk of bringing something into a nursing facility that we
Hmm.
know is really at high risk. Similarly, with people who live at home, are there ways that we can strike the right balance? Because just like you said, many of these situations are not optional, and as
Hmm.
we get into stages where this is really prolonged, we need to be thinking about how we can strike that right balance.
Hmm. And there's a question from Karen about if there is a different advance directive specific to addressing COVID or a way to maybe modify one that you have. You mentioned a goal that was specific to COVID. So how do you?
Yeah, great question. There are no advanced directives that are specific to COVID-19, but advanced directives have, especially the version of it that I posted in the slides from prepareforyourcare.org.
Hmm.
It's a really big packet. It's like 15 pages, and there's tons of open sections where you can write in specific wishes or kind of your type of medical decision making that's specific to COVID-19. And
Hmm.
I would say also that advanced directives are a vehicle to help you have conversations with your medical team or family members. So if there's some nuance there, you should definitely let your family members know. There's also sections within the advanced directive to indicate how flexible you want your decision makers to be. Should they should they follow your directions in that to a T, or should they have some flexibility involved in there? Should they consider trials? So there's a lot of nuance that can actually be included in the available documents.
Hmm.
Great question.
And so just want to encourage people, we have another 5 minutes to add your questions. This has been a great discussion and I have plenty of questions. So just curious, your thoughts. It sounds like you've been involved in working with people in hospice and nursing homes, and just around the shortage of PPE and how that impacts the risk for people and kind of decision making around, will hospice, do I want hospice coming into my home? What are the requirements for PPE? Do I, want to take someone out of a nursing home or a facility if I'm worried about the risk?
Yeah, these are such great questions. I guess the first thing I would suggest is if you're worried, it's reasonable to reach out to um, a facility or to a hospice agency and just learn what are their current standards. As I mentioned before, things are changing. The standards are changing on a week to week or even day to day basis. Even for all of us, up until a couple of weeks ago, there wasn't a universal masking policy, and now there is. So we're kind of trying to adjust as we go. In terms of PPE, yeah, it is just, it's hard to overstate how important it is, especially in nursing facilities, to get that type of equipment to limit the spread between residents. Nursing facilities are already short-staffed, and many people are even calling out sick or have detected disease, and so they're working on even more bare bones staffs. And so in those situations, it can, people are really at high risk for rapid transmission, and that's what we've seen. And so I think what I found is nursing facilities have been really on it, incredibly dedicated staff. They really care about the people who live there, and they're working really closely with the Department of Public Health to try to maximize those standards. And so my hope is that, my sense is that they're getting there with getting adequate PPE. And I think we're just going to be learning about the situation as it moves forward.
And I have another question. I know that you work with veterans at the VA, and I imagine that you work maybe with people who are in an urban setting and a rural setting. And I'm curious if there have been any differences around what people's experiences have been in those settings.
Yeah, great question. I find that I'm learning so much from people who are in different counties across California about what they're experiencing. For example, I just spoke with a patient who is in Lake County who mentioned that there was some deployment of National Guard, and there have been public testing drives that have been going on in certain parts of their county. And even other counties, someone mentioned antibody testing before, that people are finding ways to really figure out how much spread there has been in local communities. So my hope is that people will continue to understand the risk within different communities or different counties, so that it can guide how we hopefully get back to normal in days to weeks,
Mm-hmm.
months.
Yeah. And I guess I'm curious. Well, next week we have our speaker is Patrick Arbor from the Institute on Aging. I think you're familiar with him. He founded the Friendship Line, and he'll be talking about collectively grieving the world as we knew it. I guess it's a question around, are we, will we get back to what we knew as normal? It might be a while. There was one other question from Judy, again, around how effective is the antibody testing? And I know this is kind of outside your area of expertise, but I guess if you have anything else to add about that.
Yeah, I would say that I would talk with your primary medical teams about antibody testing. I don't want to give wrong information, so I would definitely reach out to them to figure out if that's something.
Yeah, the latest I saw is that, the test had been kind of conditionally approved, had been faulty, and that I think there are tests now, there are studies going on now to kind of actually evaluate the effectiveness. So I don't think that we can rely on that as any kind of protection. just as a side note, I think the head of the Department of Aging of San Francisco is giving a webinar tomorrow through the ASA, and I think Dr. Rutherford, the epidemiologist, has been part of an effort to train a lot of city workers to do what is it called? Contact
Contact
tracing.
tracing?
Yeah.
Yeah. The number of volunteers, I think they're over 100, and I think they're potentially getting up to 400 volunteers. So it's pretty incredible what the Department of Public Health in partnership with UCSF has been able to do. It's been really great.
Yeah.
I'm also seeing a question from Denora about whether advance directives need to be signed by a lawyer or can just be signed by the patient. So the advanced directives, they need to be signed by the patient or and by two witnesses who are not the designated power of attorney and who are not the patient themselves. So right now it can be hard sometimes to find the additional two witnesses, especially if you don't live with other people. So in that case, you can get a notary to sign the form, and in some cases you can talk with your medical teams, but there have been ways of getting
travel
virtual
notaries,
notaries or other ways
yeah.
of kind of getting around that. So,
and I guess just to add to that in some states the witnesses cannot be family members. Yeah, they certainly can't be the people named on the documents. Okay, so yeah, I think one issue around around advanced directives, certainly in people with dementia, is that they have to have capacity, and that's kind of the topic of a whole nother discussion.
yeah,
So I'm not sure why a notary wouldn't sign a form in this case. It looks like from Caitlin. And the post actually does need to be signed by a doctor or a nurse practitioner, I understand.
Yes. So the post is a medical order. So
Mm-hmm.
that absolutely needs to be signed by a nurse practitioner or a physician, because we're giving a medical order to emergency medical personnel if they come to your home, or
Mm-hmm.
it's an order to hospital staff if someone experiences an unanticipated emergency within the hospital. So that's really important to talk with your medical team and actually get that signed.
And there's another person asking about the notary process being done online. I'm not aware of those services. I've met mobile notaries who will come, to the location, but I think I'm not sure about it being done online.
Yeah, I'm not sure either. I will say though that many things are changing in our
Right, that's
current
true.
environment. So I wouldn't be surprised if someone has come up with
A way to make that
processes of doing
happen.
this. And if I find out about this, I'll certainly let Sarah know.
Yeah, and we can post on the website. That'd be great.
Mhm.
Well, we're over time, and just I want to thank Dr. Kotwal. I think this is really useful for all of us, and thanks again. And so for those, just a reminder who want CEs, you'll get an email tomorrow with a survey that must be completed in order to get your CEs. And please join us next week for Patrick Arbor at the same time, talking about collectively grieving the world as we knew it. Thanks again, Dr. Kotwal.
Thanks so much. All right, take care, everyone. Stay safe.
Bye.